Ladies and gentlemen, good morning. I think we'll get started. We don't have the much of the audience we're expecting yet, but it's 11 a.m. Ghana time, and so we will get started. I'll begin by introducing our speakers. So this is continuing in our series on the current pandemic, coronavirus, specifically the SARS coronavirus 2 and COVID-19. This morning, we are privileged to have two distinguished scientists who will be presenting to us. I'll introduce the first of them. We'll have Dr. Kwejo Asamoah-Kusi talk to us on aspects of his work. Dr. Kwejo Asamoah-Kusi trained at the University of Ghana. He got his bachelor's degree and master's degrees from the University of Ghana at Legon. He then went on to BPRC Leiden in the Netherlands, where he obtained his Doctor of Philosophy degree. Dr. Asamoah joined the Noguchi Memorial Institute for Medical Research at University of Ghana in 2011. Since then, he's had some very vigorous research going on. He's currently a senior research fellow in immunology at Noguchi. His research is on pathogen-induced immune responses, especially against Plasmodium. He works on multi-allele vaccine formulation strategies with the goal to overcome strain-dependent effects on antigen polymorphisms on immune responses and finding pathogen peptides that elicit protection-associated T-cell responses in malaria-infected persons. As we all know, malaria is a big part of our lives, those of us in the tropics. He also has ongoing work on HBV, malaria co-infections, and their joint effect on liver health, and is a lead immunologist on clinical trials at Noguchi. So, ladies and gentlemen, without much ado, we'll hand the floor over to Dr. Kwejo Asamoah-Kusi. Following him, we'll have Dr. Arthur Kennedy, who will give us his take on some clinical aspects. So, Dr. Asamoah-Kusi, thank you.
Okay, so thank you very much, George. It's a privilege. I hope you can hear me.
Yes.
Okay, all right. So thank you very much. Like I said, it's a privilege to have the opportunity to speak to us. Based on the introduction that George has given, you know that I'm typically a malaria person, but like the saying goes, we are not in normal times. So everybody's expanding their reach. And I'll be telling us or trying to answer the question whether COVID-19 vaccines as we have it now a means to ending the pandemic. I will have my own opinion at the end of this presentation as to whether the vaccines that are available now and the capacity that is there now is enough to end the pandemic. And I'll invite you also to, during the Q&A session, provide me with your opinion. So I'll just begin by giving a bit of the biology and immunology of the virus. Sorry. Okay, so this is just an overview of where we stand as a country, Ghana now, looking at the number of cases that have been confirmed as of yesterday. I pulled this down yesterday. 794 deaths, or a little over 95,000 cases. But of course, we know that these numbers are grossly underestimated because these numbers are based on how many people are actually seeing the need to go through a testing system and therefore getting the data onto the Ghana Health Service database. But there is indeed a lot more cases that are out there that we probably do not know of. So confirmed cases here with the caveat that these are the numbers that have gone through some form of testing that is captured by the Ghana Health Service. Now, this slide shows the 2 peaks that we've had since the first cases were recorded in, let me get a pointer. Since the first cases were recorded in March 2020, we've had 1 peak somewhere around July, August last year. And then we had our second peak around February, most likely due to all the activities that probably took place in December and January, the elections and all. And then we currently, I'm seeing a little thing growing here. I hope it's just something that would flatten off and not come back as a third wave. But currently, this is what our picture looks like in terms of the cases that we are recording. So basically, vaccination is based on one's immune system responding to the presence of something that looks like the pathogen that you're vaccinating against, but it's not. Now, even if we take infection, and so what I have on the slide goes for both infection as well as for vaccination. When you are infected or you get vaccinated, you have cells that are part of the immune system known as antigen presenting cells that would pick up either your infection or your vaccine and be able to do 2 things with it. A lot of work in the background ends up in 2 main things, either the activation of what you call the cytotoxic fraction of T cells that would kill infected cells through contact and recognition of antigens of the pathogen on the surface of the infected cell by MHC, or you have presentation of what the antigen presenting cell is carrying to B cells that would then make antibodies that are specific to the pathogen that was shown to them by the antigen presenting cell, and therefore block the pathogen from even gaining entry into host cells and then multiplying. I present this because most of the time our focus is on antibodies, and we completely forget that T cells are also a very important factor when it comes to immunity against viruses. We just recently had a screen of those who have been vaccinated in our institute, and when we sent the results out to people by text, we had almost 66% that had antibodies, and then about 34% who didn't have antibodies after their second shot. And the initial reaction for those who didn't show any antibodies is, so did the vaccine do anything in my system? But that is it. You would not always expect antibodies to be the key driver. Of course, that is what you can easily measure in terms of assessing your vaccine by a rapid test. So these 2 arms can be triggered, and they both would help in providing the immunity that is required. So this is a structure of the virus, and I'm showing this for the purpose of seeing the antigens of the virus that are targets of immune responses. So you have 4 basic antigens, the spike protein, which is in green here on the surface, and then you have the membrane protein, the envelope protein, which are all embedded within the bilipid layer. And then you have the nucleoprotein, which is what is used to package the nucleic acids of the virus. So that's internal. And of course, you have several other antigens, accessory antigens or proteins. And then you also have open reading frame proteins that all make up the complex virus. Now here you're looking at entry of the virus into host cells. So this is a host cell and through what you call the angiotensin converting enzyme 2 receptor. That's a receptor or a protein that the spike proteins of the virus interact with in order to have the virus gain entry into the host cell. And it is, for now, most of the vaccines aim at blocking this interaction between the spike proteins on the surface of the virus and this ACE2 receptor. So this is a list of antigens that you can find within the parasite, some eliciting CD4 T cell responses, those eliciting CD8 responses, and those that elicit antibodies as well. But if you look at the immunogenicity of these antigens, you see two that clearly stand out: the spike protein, which is on the surface, and the nucleoprotein, which is embedded within. That's what's used to package the nucleic acids of the virus. So these are the two most immunogenic antigens that you can find, at least in terms of antibodies. But most of the vaccines, or let's say all of the vaccines we have now, are based on either the spike protein or the whole virus, and not on the nucleoprotein, once again, because of the internalization of the nucleoprotein. It's an internal antigen and therefore would not be easily accessible to the immune system. And that makes it very interesting, the fact that an antigen that you find on the inside of the virus, which can only come to the outside once the virus disintegrates, is that immunogenic. But that is what we find. So far, these are the platforms upon which the vaccines have been developed. So you have the nucleic acid-based ones being the newer and novel approaches, and then the classical approaches that we know based on protein or the whole virus either killed or attenuated. Most of, or let me say, the attenuated or killed virus vaccines we have now are all coming from China. And then we have the Novavax vaccine that is based on the protein. And then you have the viral vectored or DNA RNA vaccines, all looking at or focused on the spike protein. So right from the protein vaccines to the RNA, DNA, and viral vectored vaccines, all of them are based on the spike protein. Now, currently around the world, this is probably a few weeks old, but this is the number of vaccines that are at various stages of development. As you can see, a lot of them still at a preclinical stage. That's in animal testing, laboratory testing, all the way to about 16 that are currently being offered to populations the world over, but with 5 that are being monitored in phase 4 or post-market surveillance studies now. So it's a huge pipeline, a lot more yet to come. It looks like a lot of these are either based on the whole organism, either partially killed, attenuated, or fully killed, as in the inactivated vaccines, or based on either the DNA, RNA, or protein that for the spike protein. So DNA or RNA that codes for the spike protein, or the spike protein itself. So it's a very huge pipeline, and we are expecting that a lot more of these will come through in the coming weeks to months. Now, if you look across the world in terms of the numbers of persons who've been vaccinated, you see the US here leading with probably getting a little over 150 million persons vaccinated on some level. And then the next, in terms of numbers, is India, and then the list goes down that way. And this is data that I accessed yesterday. But if you look at how the vaccines are performing, and here on the slide, presenting information on virus neutralization. So looking at or taking antibodies from the serum of persons who have been vaccinated with these vaccines and testing them in vitro to see whether they are able to block virus entry into host cells. And as we see here, the B117 is the alpha strain. Now we are not supposed to refer to them by country names. So that, if I may, is what was found in the UK, named initially as the UK strain. And then the B1351 is the South African version. And then you have the Gamma, or the Brazilian version, as the P1. And if you look at this work that was done sometime in March, or reported sometime in March, all of them were not doing very well against the South African strain. Okay, so they all have reduced effectiveness against the South African strain. But the Pfizer and AstraZeneca vaccines did show some effect against the Brazilian strain. But currently, as we have the Delta strain, which is also a variant of concern, and I haven't seen any data on virus neutralization from, but there is data on a field trial, which I'll show on a slide later. But this paints the picture of variants that probably the vaccines that we are using now are not going to be effective against, and therefore we need to be careful and need to be looking back at the design of these vaccines to see how we can improve upon them. But like I said, this is in vitro analysis of antibodies from these vaccines, so that has its own drawbacks. But if you look at real life situations, this is a table showing data from India, where they're using two vaccines, the AstraZeneca here, Covishield, and a Covaxin. And you are looking at breakthrough infections. So for this vaccine, you have almost 0.04% of persons who have been fully vaccinated still getting infected. That looks very small. And indeed, if it remains that small, that will be quite good. For the Covishield or the AstraZeneca vaccine, it's about 0.03. And indeed, when you also look at the US, CDC is reporting a 0.01% breakthrough infections, with 2% of that 0.01 having infections that resulted in deaths. And looking at the numbers the US have vaccinated, this data is generated and estimated to about 10,000 breakthrough infections. And then you have 2% of that 10,000 breakthrough infections resulting in deaths. So that is still quite a huge number, although the proportions in terms of the breakthrough infections look that small. And that maybe should not be a cause of worry now, but knowing what you are dealing with and the rate at which variants are showing up, we should begin to look at how to get around this problem. Now, added to that, if you look at this figure here and look at Seychelles Islands as a nation that has been able to immunize the greatest proportion of its population compared to any other country. So Seychelles has done a little over 70% of the population, and it's because it's a very small nation, just a little under 100,000 persons. And they've done over 70% of the population, and you would expect that that should be approaching some herd immunity threshold. The vaccines they've used are two, basically. So Sinopharm from China, that is an inactivated vaccine using the whole organism, and then you have the AstraZeneca vaccine, that is the remaining 43%. Some Sputnik V vaccine has been used, but are very negligible. But if you look at these and you consider the fact that from the middle of May 2021, Seychelles Islands is seeing a spike in cases, and they're having a wave of COVID infections. That makes the effectiveness of the vaccines that are being used a bit skeptical. Currently, they are seeing 37% of cases that they are reporting as breakthrough infections, that is in people who have been fully vaccinated. And although most of these are asymptomatic in nature, but 20% of that number are actually ending up symptomatic and being in hospital. And these are people who have received the 2 doses of the vaccines as prescribed. So what is happening? Is it that the vaccines are ineffective? Is it that you have certain resistant strains, either ones that we know now or new ones that have not been sequenced, showing up in that population? Is it a relaxation of the prevention protocols? It is still not very clear. But if I go back one slide, if we pick most of the countries in this top echelon of those who have vaccinated the greatest proportion of their population, and we take the first case of Israel. Israel has done over 60% of their population. Vaccination started in December 2020. They have mostly used the Pfizer vaccine, and you see a rapid decline in cases between February and now in Israel, to the point where currently there are places in Israel where wearing of masks is no more mandatory. Then you also look at the case of the UK, where the majority of vaccinations have been AstraZeneca. Of course, there is also the 3 other ones, Pfizer, Moderna, and the Johnson & Johnson vaccines have also been used there. But over half of vaccinations currently are with the AstraZeneca vaccine. And this is the trend that you see. Okay, so you currently having a rise in cases in the UK. Most of it probably due to the Delta strain. And then we take a look at one other country, Mongolia, that is also using mostly the AstraZeneca vaccine. And once again, vaccination started somewhere in February, but this is the trend that is seen there, probably now coming down. But you see a huge increase in the number of cases that they are recording. And then we also look at the case of the United States, which is also using the mRNA vaccines more. They have just introduced the Johnson & Johnson vaccine. Vaccinations began December 2020. And there also you are seeing a decline in cases in most places on average. So then the question one would ask is the AstraZeneca vaccine that effective? Because where it's used significantly, you are seeing cases rise concurrently, and that is a cause for concern. But of course, this is recent data that has emerged from AstraZeneca, and this is indeed the data that the Ghana Health Service is basing their press release through the Ministry of Information recently on. This is treatment or vaccination of people, or hospital management of people who have been vaccinated with the AstraZeneca vaccine in the UK. Between 12 April and 4th of June, about 14,000 persons who are reported to hospital with the Delta variant. And what they are reporting is a 92% effectiveness against hospitalization. But of course, if you look at symptomatic conditions, then it's slightly lower. So you're looking at 74% against the Alpha strain, which is what the UK reported some time back in August. And then if you look at the Delta strain, it comes down to about 64% against the symptomatic disease. So this is new data that the company is reporting. But of course, even here, if you look at symptomatic cases, not hospitalization, you realize that it is doing less than what the other vaccines probably would do. Now, so what really can we do to probably turn this around? And I've just put a few suggestions here. Looking at the current situation that we have on our hands, probably it's time to start reviewing these vaccines to get them focused more on protection that would be effective across different variants, and not still focusing on making vaccines that are targeted or have components based on just one or two of the variants that we currently know. And this is very important because we still have variants emerging, and until we begin looking at strain transcending or variant transcending vaccines, we might end up in a situation where we lose the effectiveness of the vaccines that we currently have. And then the other thing is, would repeated or periodic vaccinations be required? As at now, we do not know for how long protection would last. There have been projections for 6 months, for 1 year. I know people who were vaccinated in clinical trials for these vaccines from last year are still being monitored to see exactly how long protection would go. But should we already start looking at booster shots in terms of our COVID vaccinations, like is done for the flu, if we are to maintain the gains that have been made with these vaccines? And then also the possibility of providing support or aiding the current vaccines that are available, looking at cross-reactivity with targets on other pathogens, as well as what is known as strain immunity. And on the next 2 slides, I present these 2 concepts. So there is information that shows that when you have the measles, mumps, rubella vaccine, and especially of the measles component, you have components of the surface proteins of the measles virus that cross-react with the SARS-CoV-2 virus. So this work done in Turkey was able to show that in persons who had recently received the MMR vaccines, you have a lower infection rates of COVID-19 in that population. And indeed, a study that was published recently has shown the potential overlaps. So here you have the COVID spike protein sequence as against the measles fusion glycoprotein sequence. And all of these sequences here in these regions are regions where you have similarities in terms of the amino acid composition between the measles virus surface protein and the SARS-CoV-2 protein. So this is one very important thing to look at. And then, of course, there is what is known as strain immunity, where you are looking at certain innate immune cells acquiring a memory phenotype such that when you have exposure to one pathogen, you have epigenetic reprogramming of some of these cells such that they are able to remember a second infection or with a different pathogen. Okay, and so this is another thing that probably might also be useful as an aid for helping COVID vaccines. Now that especially they are so difficult to even find, can we fall on other vaccines to help the fight against SARS-CoV-2? And on the basis of these 2, there is currently what is known as the Crown Coronation Trial that is ongoing in a number of countries. In Africa, the sites for these are in Zambia, in South Africa, and in Ghana. And then there is also trial sites in the United States, in the United Kingdom, and in Canada. Now, the primary focus of this trial is to look at whether the MMR or MR vaccine in some countries would be effective at reducing infection rates in hospital workers or healthcare workers in these countries. So most of the countries have now completed the trials. Data analysis is ongoing. Ghana and I believe Zambia are still open, either Zambia or South Africa. But for Ghana, the trial started a bit late. It's been done at Noguchi here. It started a bit late when COVID vaccinations had already started. So what we did was to now have a new design where we are looking at giving the measles rubella vaccine as a primer, and then following it up with 2 COVID shots, so the AstraZeneca COVID vaccines that we have in country. So at the beginning of the trial, and we have completed this first part, we have randomization to give 2 groups of participants, the MR vaccine and then a placebo, and then follow it up a month later with with the first COVID shot, and that is where we are now. We are currently administering the first COVID shots, and then 2 to 3 months later, give the second shots, and then to be able to see whether those who have the MR vaccine primer are able to make an immune response that is more durable compared to those with just the COVID shot. So that trial is currently ongoing here. Now, another thing that we are talking about a lot, and for Ghana, this seems almost like an impossibility, is the attainment of herd immunity. So this basically looking at if you have an unimmunized population and a population that is naive to the SARS-CoV-2 virus in this instance, if you have a few infected people within a few weeks to months, you can have them infecting a lot more people, and that will, cause a lot of deaths and all that. But in a population where you have persons immunized, shown in yellow here, or this could actually also be due to a natural infection. But if you are looking at a situation of immunization, then in a population where you have a lot of people immunized, the chances of infected persons transmitting is much reduced, such that although you can have some transmission, it will be very limited, and you have people, even people who have not been immunized, being protected. But this would require a significant portion of the population in any country being immunized. And so this paper from McIntyre that did a modeling that shows what proportion of your population needs to be immunized in order to achieve or attain herd immunity. So if you are using a vaccine that is at least 95% efficacious, then you are looking at immunizing about 63% of your population in order to achieve herd immunity. But as the vaccine efficacy reduces, then you need to immunize more and more people. So down to 60% efficacy, you need probably to immunize everybody before you can achieve this. And if you are down or below 60%, and definitely of efficacy for your vaccine, then that is almost unachievable. But these estimates or this modeling was done based on having an R0 of 2.5. That is, if you have one infected person able to infect up to 2.5 people. But if you have a variant of the virus that is transmitted even more quickly, or that whose R0 value is higher, then these estimates would shift definitely. So beyond all of these, there are additional things that would affect a successful global vaccination, and some of these are the rate at which vaccination is progressing now, which seems very slow. It is going on rapidly in some countries, but in the majority of countries globally, it is proceeding at a very, very slow rate. Okay, and that would affect the global agenda of eliminating this virus in the shortest possible time. Of course, the vaccine shelf life and demand and supply issues relating to what I've just mentioned already would also affect whether we are able to successfully vaccinate populations globally. And then the issue of production sites and the capacity for production. Very few production sites are available globally. And it's because this is the first time we are looking at making vaccines, okay, for the entire global population. Most vaccines are made for regions of the world, not for the entire world. So all of a sudden, the the vaccine production sites that we have around the world seem so few compared to the capacity. So here are countries where we have production sites and the capacity of production that is going on there. And as you can see, a lot of these are outside Africa. In fact, for Africa, the only country that is shown on this is South Africa. And so we have a long way to go in terms of production of vaccines to feed the entire global population. And then also with the issue of funding, these are the countries that are doing major funding of vaccine production now. And of course, they will have to take care of their populations before they move out to look at others. But one thing that makes this dire is the fact that this is a disease that one country or one region cannot afford to say we have eliminated it in our region and then that is it. It can easily spread from anywhere, and therefore a global effort to do this will be better than a regional effort. But of course, everybody needs to come to the table to make this happen. So in rounding up, I would say that COVID-19 vaccines seem to be holding the fort for now, but it can rapidly change, especially because of vaccine shortages and also because of the emergence of new variants. There are so many variants now. It's just a few of them that have been classified by the WHO as variants of concern. Those who are on the watch list yet to join the concern group are variants of interest. And it's likely, very likely, that we'll have a few more coming through to the variant of interest section. So looking at these, vaccines may be doing something now, but we need to be watching out for what comes up next. And then looking at the very slow rate of vaccinations, attainment of herd immunity in most places is very questionable. And so maybe that is not something that we should be so much focused on currently. And then as things stand now, we also are not very sure of how long protection lasts in terms of vaccinations. And this will be a huge factor in determining whether seasonal or annual boosters will be required. So that is another factor that mitigates against a vaccination. And in my opinion, with the current circumstances of vaccine shortages, of the emergence of variants and all of those, vaccines alone cannot guarantee elimination success. And it is very important that we realize that China was able to control the SARS-CoV-2 infections without vaccines. They did that with the prevention protocols. And I think especially for many African countries, and in fact, countries that are struggling to get vaccines, a strong emphasis on enforcing the prevention protocols will stand us in a better position to be able to control and eliminate this disease compared to the use of vaccines. It's unfortunate I'm a vaccines person, but the picture I see now does not speak to us winning this war with or this fight with vaccines alone. And so I think we need to look more at the prevention protocols as well. So that's where I bring my talk to an end. Like I said, I concluded with my opinion, and I would invite your views, your opinions, and questions. Thank you very much.
Thank you very much, Dr. Kojo Samuel Kusi. Thank you so much. This is very a very enlightening update on events around the current vaccination effort, the current mitigation efforts that are taking place around the world, particularly what is happening in Ghana. I'll ask the audience to hold off on questions until we hear the second presenter. And then, as we've always done, we'll reserve the time afterwards for questions and answers. So, ladies and gentlemen, we have another distinguished scientist, a clinical scientist, presenting to us, as we've done in the past. So Dr. Kobna Atta Kennedy is a family physician, educated in Ghana, educated in Canada, educated in the United States. So this journey started from Tafo Pankrono, LA Middle, Ose Chiriche in Kumasi, Presbyterian Boys, also known as PRESEC in Legon, University of Ghana, medical school. He also made his way through University of Toronto. He also had his medical training at the Medical College of Wisconsin, University of Dallas, from where he, University of Texas at Dallas, from where he had his management training, management degree. Dr. Kennedy, besides being a physician, is more well known in Ghanaian circles as a political activist. In 1983, he was the national president of the National Union of Ghana Students. And we remember those days when we were fighting against the military dictatorship. He in 2007, he was an unsuccessful presidential candidate for the New Patriotic Party. Today, he's going to offer some insights, the primary care physician's insight. So without much further ado, we'll hand over to Dr. Arthur Kobna Kennedy. Thank you. Oh, hello, I forgot to mention that Dr. Kennedy also, for a while, was affiliated with the University of Cape Coast Medical School and the University Teaching Hospital in Cape Coast. Thank you.
Good day. Can you hear me?
Yes. Yes, we can.
Okay. Are my slides on?
Yes.
Okay.
They are on. I would, if you can put it in presentation mode, but it's fine as is.
Okay.
Yeah.
So good morning. I enjoyed Dr. Asamoah's talk very much. And as George has said, I am more known sometimes for politics than for medicine. And one of my friends said that at Legon, I majored in Alute and minored in medicine. So this pandemic has been challenging for all of us. And the outline of my talk will be, I would go to Sir Robert Hutchison for what I consider my all-time favorite quote in medicine that has always been relevant. Then I'll tell you about Rebecca's burden and discuss sources of information as this pandemic rolled, and for once in our life, there were no papers from renowned academics like our speaker and others to guide us, and we were making it up as we went. Then I will talk about how we went about evaluating and diagnosing COVID in the office, how we treated patients, talk a little bit about employee health, and then public health perspectives. I'll make a few remarks that will mirror some of those that the doctor has offered, and I will have reflections, and I hope our question time will be robust and interesting. Sir Robert Hutchison said, from inability to let alone, from too much zeal for the new and contempt for what is old, from putting knowledge before wisdom, and science before art, and cleverness before common sense, from treating patients as cases, and from making the cure of the disease more grievous than the endurance of the same. Good Lord, deliver us. And as we go through all the changes, I think this disease put almost every institution through a stress. And we saw how WHO and China and the American government and EU and Africa all fared. So we can reflect on all those things. But let me begin with what I call Rebecca's burden. A few months ago, I finished my taxes, and as Prof. Kwame can attest to, in America, tax season is a very challenging time. And after the tax lady gave me the bad news about how much I owed, etc., we started chatting socially. And she said, you know, Doc, I lost my mother and a sister to COVID in the last year. And of course, my wife and I expressed our condolences. And she said something bothered her. What bothered her was that her mother was admitted to hospital. And when she got to the hospital, they told her that, by the way, your mother is in her room. We've taken her to her room. We've done her COVID swab, but the results are not in yet. But you can go in and say hello to your mother. He said she got up to go. Then it occurred to her that maybe her mother might have COVID, which is why she had been admitted. So she decided to pass on the opportunity to go and see her mother. And 4 days later, her mother was dead. And she didn't have a chance to, at first, see her mother face to face. And she said something very interesting. She says, Doc, I am very burdened by the fact that because I was afraid of catching the disease, I couldn't go see my mother. And yet, people like you and the nurses there who didn't know my mother were risking their lives and their health to take care of her. And she said, I look at healthcare personnel very differently because I look at my own fear, which led me not to see my mother, and the courage of these people who always put their lives at risk so they will take care of people that they don't know. That is the calling of our profession. Anyone, like any of these on the panel, as well as the many healthcare workers around the world, sometimes we take what we do for granted, but it is very significant. Moving on, we'll talk about how we got information. I decided that almost every morning I'll check the CDC website for new information. I'll look at what the WHO was saying. I'll look at medical journals. And then one source that was actually very useful was the Wall Street Journal, and to a less extent, the New York Times. The Wall Street Journal is probably one of the widest circulating papers here. And they had very up-to-date articles, which will point me to journals that I needed to go check up. And sometimes there were programs where, like C-SPAN, had pros and cons discussions that were very, very insightful. And sometimes, while all the information wasn't reliable, they guided me about where to go for further information. Another source that was very useful was my professional colleagues, Professor Jipong at Yale, Dr. Taylor in New York, and I was always reaching out to them. So at least once a week, I would call them and ask them, what are your hospitals doing? What are you guys thinking? And for example, I followed the hydroxychloroquine's rise and fall through how it got on the Yale University Hospital's treatment guidelines, and then was young, then later on couldn't be put there. So all those things were very, very useful information as I dealt with my patients. So initially we were all a little paralyzed for about maybe 2 weeks. Everything was at a standstill because we didn't know what to do. Within a month, we all figured out what to do. They had put in plexiglass and other things in our offices. And what happened was that if you were a patient, you walked in, you signed your name, you went and sat back in your car. Then somebody would talk to you over the phone and decide whether you had signs and symptoms that warranted being tested. Then they brought you back into the office, and the routine was that if you met certain criteria, you had a test even before the physician saw you. And both the physicians and nurses were dressed in garbs, the N95 mask to see suspected COVID patients with a face shield, a gown, and gloves, which was a little uncomfortable. Then you went in to see the patient, and 9 out of 10 times you would have the results. In my office, we got the results in about 15 minutes. So by the time you walked in, you had the results and your talking point. And people did it very differently. There were people who basically, they just walked in, handed you your results, and got out as fast as they could. Of course, the focus on COVID led to a few surprising things. Like I remember the patient who, and actually work sites drove a lot of this. You had almost every work site where if you got in, you had to have your temperature taken, or if you had sniffles. So a lot of people were sent for COVID tests. For example, there was this lady who was sent to my office for a COVID test. The test was negative. Of course, they did the test before I saw her. And then when I walked in, I said, "But do you have any other illnesses?" She said, "Yeah, I'm a diabetic." When was the last time you checked your sugar? She said 2 months ago. And when we checked her, she was about 275 milligrams per deciliter. And maybe the problem was the diabetes rather than COVID. But as soon as she said she didn't feel well, everybody was focused on the COVID right away.
Dr. Kennedy, just a moment. There's a request from in the chat. Are you able to click on the presentation mode button? I think it's
okay. Where is that?
This is Google Slides, so it's a little different from PowerPoint. If you go to, no, it's okay. I think you can go on. I because I'm not. Yeah, that's it.
Is it better?
Yes, we see the full.
Sorry about that.
Thank you.
Okay, so the tests that we use mainly molecular and antigen type tests. The molecular tests are based on RNA transcription and nucleic acid amplification. The antigen tests are the rapid test, and they normally deal with a protein rather than RNA. And the specimens for the molecular test are nasopharyngeal, nasal, sputum, or saliva. And then the antigen ones are nasopharyngeal and nasal. The key differences actually come in sensitivity. The specificity for both of them is high. And I assume, just to remind you, if you know that, the specificity is how reliable a negative test is, and the sensitivity is how reliable a positive test is. It turns out both of them have very high specificities. The sensitivities vary. The molecular weight have very high sensitivity, and the antigen tests are moderate. In general, the molecular tests take a little longer. Some can get you results as soon as 15 minutes, but some take days. And the antigen tests are usually fast. So most of the office tests that we see are normally antigen tests. And the cost of the molecular tests are a little higher than that of the antigen test. And it looks like when you are traveling, most people, if they had their own way, would prefer that you get a molecular test. Oh, I remember one of our physicians who got an antigen test from our clinic, which was convenient, but when she got to the airport, it was very difficult because they didn't think it was the appropriate test. So you need to keep that in mind as you make arrangements for tests. Once we got the test results, the question was what to do about management. I'm sharing with you NIH treatment guidelines, but then I will tell you what we actually used to do. The NIH treatment guidelines say that 1, management should include supportive care, reducing the risk of transmission and advising patients on when to contact the provider. That is item 1. Then 2, patients with symptoms of COVID should be triaged by telehealth, if possible, before receiving inpatient care, and those with dyspnea should be referred for in-person evaluation by a healthcare provider and followed closely to assess for worsening respiratory status. And 3, management plans should be based on the patient's vital signs, physical exam findings, and the availability of healthcare resources. In terms of specific therapy, the COVID-19 treatment panel recommends the use of one of the following combinations of anti-SARS-CoV-2 monoclonal antibodies to treat outpatients. So they give 2 different combinations of that. B, the panel recommends against the use of chloroquine or hydroxychloroquine with or without zithromax. There is insufficient evidence to either recommend for or against the use of other agents. And C, panel recommends against the use of dexamethasone and other systemic glucocorticoids in the absence of another indication. And there is a lack of efficacy data on the use of these agents in outpatients with COVID-19, and systemic corticoids may cause harm in these patients. And D, recommends against the use of antibacterial therapy in the absence of another indication. And E, healthcare providers should provide information about ongoing clinical trials of investigational therapies to eligible outpatients so they can make decisions about participation. You notice that, and this was actually just updated on May 24th by the National Institute of Health. You notice that there was a time when hydroxychloroquine was all the rage, and then as a result of global studies published simultaneously in the Lancet and New England Journal of Medicine, they were pulled back because their evidence to support them collapsed. And then it turned out that the tests that dissed them themselves were not reliable. And I think there was a whole lot of politics involved in that. And you notice the comments about glucocorticoids. So I'm going to go ahead and then discuss specific patients and what we did. And during question and answer, we can maybe exchange views on how relevant these guidelines were. In terms of my actual patient experience, beginning about the first day of March, I ordered an average of about 20 tests a day. I see about 30 to 40 patients a day in an urgent care setting. The average number of positives were about 5, and the highest I diagnosed in one single day was 14 patients. And this, I work about 5 days a week, so you can compute the numbers. Let me tell you about case 1, 40-year-old white male without symptoms, no past medical history, normal vital signs, who was sent by an employer to be because a co-worker had tested positive 1 week earlier. And that was actually the bulk of the patients we got. You know, organizations like schools and factories and others have set up their own screening criteria. So when you went in for work, they will take your temperature. They will ask you whether you have sniffles and colds, or sometimes you you will be coughing around and co-workers will be looking at you funny. And after some time, your boss will come and suggest that you should go out and get tested. So these people will show up and say, I need to get tested. So this particular patient tested negative. He was cleared to return to work and encouraged to take vitamin D and zinc supplements. Interestingly, this one came 1 week earlier, but sometimes they will come the same day. If they came the same day and they tested negative, the test was not considered reliable enough for them to be sent to work, because the guidance was that they should be tested after about 5 to 7 days of exposure. That is when the test is most likely to be positive. So if you test too early, then you should be sent home to quarantine for up to a week. The second case is a 65-year-old Hispanic male who had a temperature of 101 degrees Fahrenheit, cough, and headache for a week. He tested negative 2 days earlier at another facility. But when I asked what kind of test had been done, he said it was a blood test, which meant that it was actually an antibody test. I know that there's a lot of talk around the world about fake tests and fake medications. Even here in the US, it turns out people set up and are doing antibody tests that are being presented to symptomatic patients as quote unquote a test for COVID, which was clearly inappropriate. The test done in the office was positive. Patient's past medical history was significant for hypertension and diabetes, blood pressure 140/80, respiration 22, just a little tachypneic, pulse ox was 90%, pulse was 84. Physical exam had mildly reduced air entry on the right, white cell count was 17,000. So he was referred to hospital for admission. And I contacted the health department for the facility that did the test 2 days earlier, because clearly in a symptomatic patient, antibody tests were inappropriate. They should have had an antigen test. Case 3 was that of a 25-year-old Black female with a headache, cough, and congestion for a week. She's a school teacher with a husband, child, and a parent at home. Physical exam was normal except for right maxillary sinus tenderness. COVID antigen test was positive. He was treated with Zithromax, a Medro dose pack, and encouraged to take vitamin D and zinc as supplements. In addition to that, he was asked to monitor herself for shortness of breath. I generally, because there's a plethora of evidence and suggestions about things to do, I generally told people to monitor themselves for fever. If you are at home isolating and your temperature, despite taking Tylenol, was higher than 101, I ask that you consult a healthcare professional. If you were feeling short of breath, and I encourage most people to buy a pulse ox machine. If your pulse ox was 95 or higher, you were okay. 90 to 95, we get concerned. If it's below 90, contact a healthcare professional. And if you started feeling dizzy, you should contact a physician. If any of these things didn't happen gradually, but suddenly you felt worse, then I ask that you proceed to the emergency room, because it seems like you might require admission. So the isolation was at home for 10 days, and then the recommendation was to have the rest of your family tested. And one case that I want to hold over the discussion, I'm just telling you about it, and I'll leave you to think about it. 23-year-old medical office assistant had reported to work with a mild cough and congestion for about a few days. Her mother had tested positive a week earlier. But interestingly, she herself had had a positive COVID antigen test 2 months earlier and returned to work without retesting on clinical grounds a week after the diagnosis. As you recall, once you test positive, there were a number of ways of getting back to work. The teaching is that if the person had tested positive and been home for at least a week with the last 24 to 48 hours of no fever and generally no other significant symptoms, then without another test, they can return to work. Why? The research has shown that there are people who could continue to test positive even though they had recovered clinically and they were said to have viral particles and not active infection. So the question is, can this patient work? It led to some interesting exchanges, and once we get to question and answer, I would elaborate on what the different arguments were. Recently, the Occupational Safety and Health Administration in the US, which we call OSHA, has weighed in. This was released on June 21st, but to our disappointment, it only affected healthcare organizations. Some people think they were punting a little bit on other organizations. They said that employers providing healthcare services were affected, that these employers must conduct daily screenings of employees, patients, and visitors to determine if they are COVID positive and monitor their points of entry. They should provide personal protective equipment and ensure that these are used, except for stated exceptions, like allergies and other things. Employers with more than 10 employees must provide paid leave for employees removed from work for conditions consistent with guidelines. If you recall the previous case I just discussed, it meant, for example, that if this medical office assistant was sent home, then she should be paid while she was home. And it said you must have a written COVID-19 plan in writing, establishing policies and procedures aligned with these standards and CDC guidelines to minimize transmission of COVID-19 to employees. And they didn't mention customers, but they should have added customers. Then follow CDC guidelines for implementation of patient management strategies. Only employees deemed essential must be present at aerosol generating procedures. And for instance, in our office these days, if you come with asthma, we do not do breathing treatments anymore. We just prescribe prednisone and Donep and others and let you go and do it, because it is believed that doing aerosol treatment and others increases the exposure of staff to this disease. And employees must be 6 feet apart when indoors. I think that is there, but that rule is observed in the bridge. We still sit next to each other. There's not enough space in the office, but everybody wears a mask. And if you are not wearing a mask, somebody might gently remind you that you should wear a mask. And cleanable and disposable barriers must be present wherever necessary. Ventilation must be used according to manufacturer's requirement. Employees must be screened before each workday shift. And the screening is mainly temperature, being asked whether you have a cough, but generally they take your temperature and it's normal. It's okay. I think, as an aside, that a lot of organizations faced with the need to staff their establishment, including hospitals and clinics, were very reluctant to probe too much, because if too many employees had to go home, then the organization couldn't function. And this included hospitals. Employees must be informed of their right to protection and are protected from discharge or discrimination from exercising these rights. So if employees think that maybe they are not getting enough personal protective equipment or anything like that, you can't discharge or discriminate against them for speaking up. And employers must have adequate representation. And employers must report to OSHA each work-related COVID fatality within 8 hours of learning about it and within 24 hours of inpatient hospitalization. So if you have an employee in a healthcare facility, if they are hospitalized, you need to report in 24 hours, and if they die, within 8 hours. So what are the long-term consequences of COVID or the complications? This is still an area that is in evolution. So far, the tentative definition of post-COVID-19 is defined as the presence of symptoms extending 3 weeks from the initial onset. And then chronic COVID-19 is defined as symptoms extending beyond 12 weeks. In a CDC survey, 35% of 274 patients had not returned to usual state of health 2 weeks after diagnosis. And the symptoms were fatigue, dyspnea, joint pain, and chest pain mainly. But another study said, a German study showed that cardiac effects were present in 78%. Another study showed 64% that pulmonary effects, and then neuro and emotional effects, which are very common. And this was in a JAMA 2020 article. But to bring this home to you, let me tell you how all these abstractions we talk about matter. I have a 59-year-old employee who is an office manager, very hardworking, energetic lady that I had not seen. And this happened in November. I had not seen her for about maybe 2-3 months because I work at a lot of different offices. And one day I was working at the same place of this lady. And I noticed that when she walked from an adjoining room, a consulting room, into the office area where we sit, she was panting. It was very obvious. And I said, "Oh, what happened to you?" And she said, "Doc, this has been the case since I recovered from COVID. I just feel winded. I'm very tired." And I said, "Boy, this should be investigated. You shouldn't be just walking around like this." So going back to how I said I got information, I was going to get a EKG and a chest x-ray, but I said, let me reach out to the hospital people. I'm sure they do this all the time. So I reached out to Professor Japon describing the patient's case, and he said, yeah, we've seen people like that quite a bit, and we generally do a CT scan and echocardiogram. And he said that they were picking up a lot of pulmonary embolisms in people who had recovered and gone home. So I told this, since I wasn't her doctor, I told her about my concerns and asked her to go see her physician. Her CT scan and echocardiograms were normal, but she was wheezing. She was put on an inhaler and a course of steroids, and clinically she improved quite well. There are, of course, as the first speaker explained, public policy implications about all this. For example, as we speak, in addition to what he said, there is a lot of inequities in terms of how resources have been distributed. And when we say inequities, we should be careful. For example, a New York Times article about April of 2020 said that in all of sub-Saharan Africa, outside South Africa, there were about 2,000 ventilators. And when I checked in Ghana, they said that we had about 180 to 200, and Komfanoche, I confirmed, had about 15 of them. If you think about it, and actually there were about 5-6 African countries that didn't have any ventilator at all. At that time, the United States had about 168,000 ventilators, and South Africa alone had about 2,000. If you look at something like that, yeah, there is inequity, but maybe some of it might be of our own doing. And one of my friends joked that a country whose government owns more SUVs than ventilators maybe is not being run well. In Africa, only about 2 doses of vaccine has been administered per 100, which is 2.3% people with 2 doses. In high-income countries, some of them have gotten to about 68%, as the speaker averred to. places like United States, Israel, Seychelles are doing quite well. Chile, only 1% of Africans have 2 doses, and Africa, according to the WHO, I checked yesterday, said they need 200 million doses to reach 10% by September. Actually, I think that is mildly optimistic. About 2 weeks ago, a pan-expert consensus on a CSPAM program said that they think that the whole world will have about 10% vaccinated by the end of 2021, and about 23-25% vaccinated by the end of the next year, 2022. The problem is that this biases a lot towards those countries with resources. And when you get to countries without resources, it's going to be very difficult, because the COVAX facility that has been set up by WHO and others will help. But it looks like even when these resources are made available, the infrastructure to get the vaccines into arms is very challenging for a lot of third world countries. So I agree with the first speaker that maybe our path does not lie just in vaccines, that we should do more aggressive mask and distancing and others. But when you look at funerals and churches and others and how they are operating in our environment, it makes one a little concerned. So looking forward, I think we must maintain our vigilance with test, mask, and public education. And by the way, talking about tests, as at February of 2021, according to the CDC director for Africa, Africa has a CDC, and the director is Dr. Nkageson. He reported that as at the beginning of February, Africa's population of 1.2 billion had 30 million COVID tests. In order to give you perspective, America has a population of roughly 300 million. At the same time, America had 385 million tests. So you can weigh that. And since a lot of this is about testing, so you can find out what is happening, it means that we had significantly under-tested in Africa. And we need to do more of the fundamentals, test more, and we should fight obviously for more vaccines. But I think that when they were doing vaccine trials, Africans should have been more aggressive about offering ourselves at test sites, because it would have given us moral claims to more of the vaccines, because that is what our contribution could have been. We should encourage governments to beef up healthcare infrastructure, because this has exposed our lack of infrastructure, whether it be in ventilators, whether it be in getting vaccines, whether it be even in getting masks. And we have a lot more that we can do and we need to be doing. So I look forward to engaging you more in questions, and when we get there, I would be happy to elaborate on that debate about the MOA. I thank you very much for the opportunity to talk to you and look forward to the discussion.
Thank you very much, Dr. Kennedy. This is very down to earth, things that pertain to individuals and patients, and things that have to do directly with the care for people who have had or people who could have COVID-19. All right, so I guess the floor will now be open. The floor will now be open for questions from the audience. You can also type your questions. Otherwise, if you would want to ask it orally, if you raise your hand, I believe, Nana, you're able to grant access to someone who wants to actually speak out their questions. But at a minimum, you can type out your question and I'll read it either in the chat box or in the question and answer section. Thank you so much to our panelists. I will begin with a couple of questions, I guess, directed at both speakers, if I may. So the issue of repurposing current either treatments or current vaccines in the case of measles and rubella, like Dr. Kusi intimated, to what extent do we have to look at studies? So the example of hydroxychloroquine, this is a drug that we have used for decades and decades. And yet there were things about toxicities that, emerged all of a sudden. I mean, some of the studies were flawed and some were retracted, and so on and so forth. But if someone has evidence of success in their practice, should that be discounted while we await full study results? And in connection with that, there's a lot that is unknown. I mean, while the mRNA and DNA vaccines, according to the evidence that has been provided in today's presentations, and the efficacy is really good, but there's plenty that is unknown. Yet we're going ahead while we gather data. Shouldn't that be the same attitude towards the evidence of drugs that can be repurposed, such as ivermectin and hydroxychloroquine?
Yes, thank you very much, Prof. Yeah, I think I agree largely with that, because let me answer that with this scenario. I was once having an interaction with some colleagues from the U.S. military, whom I'm working with on some research, and the conversation drifted to they taking anti-malarials and feeling awful and a whole lot. And then it dawned on me that whenever I have malaria and I take my anti-malarials, I never really even think of the symptoms I'm feeling being an outcome of the drug itself, because I'm so focused on the symptoms from the parasite itself. So yes, some of these things could be, but I think some of them were probably shut down too early. There should have been a bit more to looking into to be able to see really what they can do. As we have the situation we find ourselves in now will require a lot of that kind of repurposing, because as I mentioned, the production size for vaccines have already become so dwindled because of the scale of vaccines that we need globally. So it's going to be very challenging looking to just vaccines for stopping this pandemic. So it would be good to still get in there looking at repurposing some of these things. And especially if they are already deployed, it makes it easier to be able to also use for managing some of the cases that we have for COVID.
Thank you very much, Dr. Solomon. Dr. Kennedy, do you have any thoughts? I mean, for
yes,
instance, yeah, go ahead.
I think that it is a very important question, because as clinicians who are taking care of patients, we should always be guided by science, but our primary concern should be our patients. On the hydroxychloroquine debate, I think there was too much politics. I am convinced that if President Trump should not have played doctor by promoting it. But having said that, I think if he had never mentioned hydroxychloroquine, the trajectory of how it was evaluated would have been very different. A lot of you on this call have grown up taking hydroxychloroquine for years. and it was safe. Even here in the US, they use it for rheumatoid arthritis and others, and it has worked a lot, and nobody has ever required EKGs and others to monitor for it. So the idea that hydroxychloroquine was unsafe just didn't make common sense to me. And it turned out, of course, that they gave higher doses to sicker patients. You get the impression that maybe people were not just trying to get information, they were trying to reach some predetermined conclusions. So I think that as clinicians taking care of people, we should always be aware of the science, but we should also apply common sense. For example, I read the NIH treatment guidelines to you. Indeed, the monoclonal antibodies work, but there are very few who are using them here because maybe of convenience, of how much people know about them. I know that in Houston and New York, they use it quite a bit, but personally, I don't know of any primary care physician in the front lines who have used it for their patients, that is recommended here for outpatients to prevent hospitalization. So we should always take into account the science as well as, in effect, the circumstance of our patients. I, for example, was very quick to, because most of the patients with diagnosis of COVID had other signs and symptoms. So if, for example, in my view, the person was congested, I would give them a steroid because it helped compared to sending them home without anything, because people were scared. And if you gave them something to go home with, you told them what to monitor for, because a lot of people were sent home by other doctors who just were told, oh, you are positive, go home. And that was a little irresponsible. You need to give them a roadmap. You need to tell them what to watch out for. And I always told people that I never got put in that situation, but if indeed one of my relatives or close friends had COVID and he was at home and not doing well, I would have given them hydroxychloroquine. I prescribed a lot of Zithromax and dexamethasone for people. And even if it didn't help all of them, there is the placebo effect. They felt like something was being done for them and it gave them hope.
Yeah.
Thank you very much. Yeah, so I mean, talking about dexamethasone versus the methylprednisolone, which is the dose pack, I mean, I don't see a world of a difference there. But the NIH recommendation, as you read it, specifically mentioned dexamethasone as not recommended. Yeah. Anyhow, yeah. So there is a question to Dr. Asamoah Kusi from Dr. Annan out in Spain. Looking at the fact that variants of the virus started to emerge very early during the spread of the coronavirus, why were the early vaccines being developed not targeted to regions of the virus that are more stable? That, in other words, that were resistant to frequent mutation or variation. Is it because such regions are non-immunogenic or due to technical difficulties in exploiting such regions for of the genetic makeup of the virus?
Okay, thank you very much, Dr. Annan, I think. Yes. So I think basically it's more difficult trying to target portions of these antigens. You might want to look at a whole antigen that can fold correctly. Once you start attempting to target these ones, it involves a lot more work. So usually the very first thing is get the smallest unit that you can use and get going with it. And then you, beyond that, start evaluating whether you need to revise that. There are instances where you've done these with antigens and realize that despite the few variants that are around, you might not need to vary it. It should be good enough. But looking at what we have with COVID now, it looks like we are getting to that point where we need to make that revision and take that difficult road of looking for what is unique across different strains or variants. Indeed, one other thing which we have done in malaria is to, instead of trying to pick out what is conserved, which is a bit more difficult to do, is to do just a physical mixture of antigens from different variants. There is normally a threshold number that if you are able to put together, naturally the immune response will be focused on what is common across those different variants. And that is one other strategy that probably might work. Maybe that might be easier. It's more expensive because then you need to make all those different variants, antigens of those variants. But definitely, I think we are at a point where we need to start looking at how to get across that. And if we had something like that, it definitely will also even be effective against maybe even future variants of or future zoonotics that are likely to come. Because looking at what has happened with SARS-CoV first one and the MERS-CoV and now this, there is every possibility that going into the future we might have more of these pathogens crossing over from animals into humans. So such a strategy will already then start looking at even those future ones that have not occurred and the possibility of targeting them as well.
Thank you very much, Dr. Summer. There is a question here. I believe Dr. Kennedy can take it, or later on Dr. Summer can offer its insights. Is there any advice for Ghanaians who only got one AstraZeneca shot and are way past due for the past the due date for the second shot? Should they start a new vaccine?
I think that whenever the second dose is available, they should take it. But frankly, talking about public policy perspectives, I think the vaccine rollout was a mistake. I think that talking from the point of view of equity, we should have focused on getting as many people as possible to get a first vaccine before moving on to the second round. Why do I say that? Because in actual fact, most of the COVID vaccines, one dose is as efficacious or more efficacious than our flu vaccines have been for years. And yet we get one flu shot. So particularly in the era of shortages, I think in terms of public policy, it would have been wiser to look for getting more people to get first shots before worrying about second shots. And actually, Britain, for example, did a variant of that and did very well. So I think particularly in resource poor areas, instead of say 10% of people getting 2 shots and being fully immunized, if 20% go 1 shot each and their immunization levels drop by 10%, in terms of public interest, that might be the best thing to do. So for individuals, I say 1 shot makes you relatively safe. Whenever the second shot comes available, get it. But to governments, I say that we should spread the interval between first and second, assuming the vaccine we pick is one with first and second doses, as long as possible, so more people get shots.
Right.
And actually, the WHO has made similar recommendations in the last few months.
Okay. Thank you very much. Thank you very much. Yeah, so we will, I think the time is fast spent. We thank the panelists, but I think, Dr. Kennedy, you had a case number 3 for which you wanted some discussion on.
Yes. That was that of the employee who had tested positive for COVID 2 months earlier and who tested positive again. And the question was whether she should be sent home to isolate or she could work. There were 2 different opinions, experts that I reached out to. somebody from the CDC kind of sat on the fence. He said that, well, you could take it both ways. Another person from Yale said that, in actual fact, most people who test positive for the disease rarely develop a second infection within 90 days. That most of the time, second positives within 90 days are due, when you do the typing and investigation, are due to virus particles rather than new infections. However, since variants were then spreading, you always had to take into account the fact that it is possible the person had gotten an infection from a different variant. But the way to get around it might be for the person to pay more attention to PPEs and others, and that as long as they didn't have a temperature greater than 101, if they felt up to it, they could work. I think that is the effect of business intersecting with health, because the interesting thing is that the same health organization that was letting that person work would advise an employee from a different organization to isolate if they were not their own employees. So those are the two sides of that coin as far as that particular employee is concerned.
Thank you very much. I will just one final thing, because we run out of time. Dr. Asamoah, you intimated that you would prefer a focus on prevention protocols, because vaccines have a limit as to what they can achieve. I don't know the extent to which that those prevention protocols are implementable in Ghana on a sustained basis. Because our experience here shows people get tired after a prolonged, it's been more than a year of prevention protocols. So in view of that, how do we combine prevention protocols with the vaccination effort as a matter of practice going forward?
Yeah. So not that the vaccines cannot be able to do the job, but looking at the current state where even production is lagging behind and availability, it calls to question whether we can still continue to base our hopes on solving this problem with vaccines. If they were available, maybe yes, it would go a long way. But because of the unavailability, but I'm looking. I always have this scenario that I refer to. I think in our part of the world, sometimes we are a bit lax with law enforcement. There is the issue now of people crossing roads and overheads having been done, for you to go above when you want to cross the roads. And for a long time, people were not following that. But in the last few months, there's been such strict enforcement that it's reduced the numbers who are crossing roads so drastically in some places. And for me, I always look to that. And I'm like, so we can do it. It's not like law enforcement is completely lacking. If we put our foot down and we want to get this done, it to get done. And of course, then it means that those who are leading this crusade also follow that example and not, flout the same rules they are seeking to enforce. I think, especially if you are in public places and it's a requirement, because for a long while now, it has been a requirement for some shops. You cannot get in if you are not wearing a mask, and people comply. So it's just a matter of having people out there, law enforcement agencies, ensuring that when you are in a public space, and especially in a crowded place, you have a mask on. I think it's possible to do. It's not impossible. And for me now, with all the politics around access to vaccines and all that, that is our surest way forward to ensure that we don't have too many variants being generated in our environment, and make thwarting the efforts of the little vaccines that we've already had.
Thank you very much. And on that note, I will, on behalf of the Convention for Biomedical Research Ghana, thank our speakers, Dr. Arthur Kobna Kennedy and Dr. Kojo Asamoah Kusi. I also thank our audience, participants for taking part in this particular webinar in our COVID webinar series. I thank you all. Thanks for your attendance and participation. The recording will be available, the link to the recording we made available to all and sundry in a short while. Thank you once again. Thanks.
Thank you.
Thank you. Bye-bye. Nana? Oh, okay, Nana has.